Hello everyone. So we will be discussing some short essay questions as well as some short answer questions from endocrine topic today. Before moving into the topics, I would like to give you certain important tips to answer the questions. Your long answer questions will be 10 marks each. Short answer questions will be 5 marks each, short answer essay questions. And your short answer questions will be 3 marks each. So for your long answer questions and your short answer questions, first and foremost, most important thing is you have to structure your answer properly. You cannot randomly write whatever comes to your mind. So it is always best to start with a definition whenever possible. So always start with a definition if whenever possible. Like for example, you get the definition, you get a disease name. So you can start with a definition of what that disease means. And then go ahead with subtopics, such as if any disease condition is asked to you, you can make a few subtopics, such as you can first mention the causes, what are the causes of the disease, and then you can mention pathophysiology of the disease, and then you can go ahead and mention symptoms, and then histopathologic findings. If there are any findings specific of the disease, you should mention that, and then you can mention the treatment. So these are you can structure your answers based on these subtopics. Always try to include diagrams. Your diagrams need not be perfect like textbook diagrams, but if you have some illustrations possible, if you have some illustrations, it will always be helpful, and your examiner will get your paper will become more good, and you might score more marks with your flowcharts, diagrams, and also tables whenever possible. So for short answer essay question which has been asked many times is Cushing syndrome. I will be discussing what Cushing syndrome is. I will review a bit of your physiology, and then I will tell you how to structure your question. So this is how I have structured this answer. First of all, I mentioned the definition of Cushing syndrome. Cushing syndrome is a disorder which is caused by excessive levels of cortisol in the blood, and is often due to prolonged corticosteroids or endogenous overproduction. So two things. First, Cushing syndrome is produced because of increased corticosteroids. All right. So it can be either endogenous, which endogenous means it is produced within the body, and it could be exogenous. Exogenous is somebody is taking external corticosteroids, ingestion of external corticosteroids. So these could be two reasons of Cushing syndrome. So I will just review a little bit of your physiology over here. So where does cortisol gets produced in our body? We're talking about endogenous Cushing syndrome over here. So where is cortisol produced? So cortisol is produced from the adrenal cortex. All right. So how does cortisol get produced? There are regulatory signals which stimulate the hypothalamus, and from the hypothalamus, there is a hormone known as corticotropin releasing hormone, which is produced by the hypothalamus. This in turn stimulates the anterior pituitary to produce adrenocorticotrophic hormone. And adrenocorticotrophic hormone stimulates the adrenal glands to produce cortisol. Okay. So whenever cortisol is increased, it can be because of, again, endogenous Cushing's can be because of two causes. Endogenous Cushing's we discussed is because of cortisol producing within the body. All right. So endogenous cortisol can be because of two reasons. One is because of increased pituitary ACTH production. What will happen if there is a pituitary tumor? ACTH production will increase, and which in turn will increase the cortisol production from adrenal gland. Right. So it is because of pituitary cortisol production. Pituitary ACTH production, which can be because of a pituitary tumor or a pituitary adenoma. What you should remember is when there is a pituitary adenoma, and because of that you have Cushing syndrome, it is also known as Cushing's disease. So because of a pituitary adenoma, you can have increased ACTH, and because of this increased ACTH is nothing but adrenocorticotrophic hormone. So this hormone increases the production of cortisol in the adrenal gland. All right. So this is one of the endogenous causes. Second is when there is a adrenal tumor itself. When there is a tumor in the adrenal gland, that will also directly increase the cortisol level in our blood. Okay, so Cushing syndrome can be endogenous as well as exogenous. Exogenous is when somebody is taking steroid hormones for some other condition. It can increase the levels of cortisol in our blood and result in Cushing syndrome. Can be endogenous. Endogenous is when cortisol is produced within the body. So within the body, cortisol can be produced from either the pituitary by increase in ACTH because of a pituitary tumor, which is also known as Cushing's disease, or it can be because of an adrenal tumor, which can directly increase the cortisol levels in blood. Okay. Or there is another way where cortisol can be produced, which is ectopic ACTH production by tumors. There are certain tumors which can produce adrenocorticotrophic hormone. For example, if there is a smoker and he develops a lung tumor, and this lung tumor produces ACTH. Okay, so what will happen if this lung tumor produces ACTH? This is abnormal. This doesn't happen in normal condition. Normally, pituitary produces ACTH, right? So when this lung tumor produces ACTH, this ACTH will increase cortisol production in the adrenal gland, right? So one of those tumors which produces ectopic ACTH is small cell carcinoma of lung. Okay, so these are the three reasons by which Cushing syndrome can be caused. Now, what is the role of cortisol? To understand the signs and symptoms, we need to know what is the role of cortisol. Cortisol is produced by the adrenal cortex. We know ACTH is being produced, and ACTH increases production of cortisol within the adrenal gland. So what does cortisol do? Cortisol has many functions. Cortisol is a steroid hormone. As we know, cortisol has many functions. Cortisol increases the use of fats by adipose tissue. It increases the use of excess amino acids. It conserves glucose, and it limits inflammation. It decreases inflammation. These functions are very much important to understand the signs and symptoms of Cushing's syndrome. So, whenever adipose tissue fat increases, there is ATP, energy production and energy consumption in most of the tissues. Glycogen gets accumulated in the liver because of glucose conservation of glucose. Okay, so even glycogen gets accumulated in brain as well. So now we'll move on and discuss the signs and symptoms of Cushing's syndrome. Now, since we know that we have increased infections, because we know that cortisol has a function in limiting inflammation. Cortisol decreases inflammation. Okay, whenever steroid hormone is given, the main reason is to limit inflammation. So whenever there is excess cortisol in our blood, main role is to limit inflammation. So what will happen if inflammatory cells and our natural immune response is suppressed? We tend to get infections more often. So a patient with Cushing syndrome can get infected very easily compared to normal people. Also, we can see that visceral obesity is a symptom of Cushing syndrome, because cortisol has a tendency to conserve glucose and conserve glycogen in the liver. Okay, so glycogen and fat conservation is a function of cortisol. Hence, visceral obesity is a symptom. Infertility and sexual dysfunction is also a symptom. Okay, cardiac disease can occur because of the same conservation of fat and energy conservation. Similarly, myopathy, osteoporosis, steatosis in the liver. This is also the same reason which we discussed, conservation of glycogen and fat which gets accumulated in the liver resulting in steatosis. Also, accumulation of the same molecules can result in neuropsychiatric disorders in Cushing syndrome. You can make an image like this whenever this question is asked to you, and it can give the examiner a great impression that you know a lot about the topic, and you might also get more marks in this topic. Next, now we'll move on to the histopathologic findings associated with Cushing syndrome. So whenever there is a adrenal adenoma, we discussed that adrenal adenoma can result in Cushing syndrome as well as adrenal hyperplasia as well as pituitary adenoma, right? So we can see that there are cells which has yellowish nodules inside them. These yellowish nodules are the lipid-rich nodules from which cortisol gets produced. So this is a feature in histopathology. Whenever there is a pituitary adenoma, you can see that these pituitary adenoma, these cells look little bit glassy and hyaline-like. So you can see that you can actually see that there is a cell here, and this is the nucleus. And peripherally over the corners, you can see that there is pinkish material. And in the center, there's not much pinkish material here. It's very glass-like, right? So this is known as Crookes hyaline change. All right. So in the center of this cell, you can see that there's not much pinkish material. And whenever a keratin stain is done, in the same case, you can see that it stains positive with keratin. These are important features of pituitary adenoma producing ACTH, which results in Cushing syndrome. Well, how will you diagnose this? So the diagnosis includes a 24-hour free cortisol test. You can do a dexamethasone suppression test, or MRI CT scan can also be done for respective pituitary or adrenal tumors. What will be the management of this case? Surgical removal of the tumor and medications like ketoconazole can be given. If the Cushing syndrome is caused by exogenous corticosteroids, then gradual tapering of exogenous corticosteroids is also recommended. Okay. The second short essay we will be discussing is pheochromocytoma. So, we know that cortisol was produced by the adrenal cortex, right? Pheochromocytoma is a tumor of the adrenal medulla. Okay. We know that adrenal gland has cortex as well as medulla, and adrenal gland is that gland which is right on top of the pituitary, and it is a triangle shaped gland. It has a cortex and a medulla. So from the adrenal cortex, cortisol is produced, and from the adrenal medulla, catecholamines are produced, which are epinephrine and norepinephrine. So what are the clinical features? Clinical features of pheochromocytoma include hypertension, headaches, palpitations, and sweating. So we'll see the pathophysiology of catecholamines. After that, we can discuss why these symptoms occur. Okay. So catecholamines are produced by adrenal medulla, and there is a tumor in the adrenal medulla which results in increased production of catecholamines. So there's norepinephrine and epinephrine, two major types of catecholamines which are produced by the adrenal medulla. So what is the function of norepinephrine? Norepinephrine is important in vasoconstriction of the skin, vasoconstriction of the viscera, vasoconstriction of the skeletal muscle. In short, norepinephrine is a very important hormone in the vasoconstriction. Epinephrine, what does epinephrine do? Epinephrine increases heart rate, dilates bronchioles, increases conversion of glycogen into glucose, increases use of energy, increase cell respiration. As we can remember from your physiology, and epinephrine is also known as flight and flight hormone, right? So whenever there is an immediate need to escape or run, so that is where this hormone kicks in. So what will this do? It will increase the heart rate. It will increase the bronchioles, resulting in increased breathing. You can increase the breathing, and increased air will reach your lungs. And you need energy when you are running or escaping from something. So you need conversion of glycogen, which is stored in the liver, to glucose. Remember that this function is totally opposite from that of cortisol, which had an energy storing function. increases the use of fats for energy, right? So this is also opposite, totally opposite to that of cortisol. Increases cell respiration. So these are the functions of catecholamines. So if there is increase in the rate of force of contraction of heart, what will happen? Blood pressure will increase. So increased blood pressure is a important sign of pheochromocytoma. Okay. So hypertension, and because of prolonged hypertension, you will have headaches, palpitation, and sweating. Okay. Anxiety, tremors, and weight loss. So how will you diagnose this condition? There will be elevated plasma and urinary catecholamines and metanephrines. By imaging also, you can see adrenal gland. A tumor can be found out in the adrenal gland, right? So these are some of the symptoms. Again, you can make a image of these symptoms in your exam. Headaches, very severe headaches, abdominal pain, pallor. Pallor, why? Because of vasoconstriction function. So whenever vasoconstriction, what will happen? Vessels will constrict and the organ which has to be supplied will not be supplied. For example, skin. Skin will receive less blood supply and hence the color of the skin will be more white and less red. Hence pallor. Severe malignant hypertension. Tremors. New onset diabetes. Increased anxiety and the feeling of impending doom, excess sweating, racing heart, nausea, vomiting, weight loss. So these are all the symptoms of pheochromocytoma. Now let's see how pheochromocytoma looks in histology. Okay, we have a classic name for this. It's known as Zellballen pattern. Zellballen is nothing but, in German, it's a wall of cells. In German, okay. It's just a cluster of cells looking like a ball. So lots of clusters of cells like this. Okay. Lots of cells like this together, put together. So this is what is called as Zellballen pattern. You can see here there are lots of clusters over here, separated by a fibrovascular tube. So this is what is Zellballen pattern. You can see this kind of a pattern in pheochromocytoma. Whatever cells you see here are large, pleomorphic, and abundant granular cytoplasm. You can see that these cells have granular cytoplasm, very pinkish and granular cytoplasm. You should remember that Zellballen pattern is a characteristic of pheochromocytoma. What is the treatment? Either the tumor can be surgically removed or can be treated with preoperative alpha blockers and beta blockers. Okay. Okay. So the next short essay question we are going to discuss is neuroblastoma. Neuroblastoma is again a tumor which arises from neural crest cells. Commonly affects children. This is not a tumor of adults. Usually, whenever you get a case of neuroblastoma, whenever you get a question regarding neuroblastoma, it's going to be a child. Okay, so you should also remember that age is very important in the prognosis of neuroblastoma. For example, if the child is less than 1 year old, the prognosis is very good. If the child is more than 1 year old, the prognosis is bad with respect to neuroblastoma. So how does this patient present? The patient presents with an abdominal mass, pain, and hypertension. Sometimes metastasis can also occur. This is not a benign tumor. This is a malignant tumor. And hence, metastasis can also occur. Diagnosis can be by urinary catecholamines like epinephrine and norepinephrine are increased in neuroblastoma. And these epinephrine and norepinephrine, they break down and produce certain metabolites which are known as PMA, vanillyl mandelic acid, and HVA. Okay, homovanillic acid. These are the two things which can be found in urine, and if they are found in urine, they are diagnostic of neuroblastoma. Though they are not very specific, they can be used as a diagnosis. Imaging, MRI, CT, and radiographic studies can be performed. Biopsy can also be performed. Okay, so this is just a chart. You have to remember this chart for your exam. Prognostic factors of Neuroblastoma. This chart is going to be very important for you, even for your NEET PG, for any exam you go, because everywhere they're going to ask prognosis of neuroblastoma. So stages, first stage. If neuroblastoma presents in a very early stage, then it has a good and favorable prognosis. If it presents in a later stage, 3 and 4 stages, it has a bad prognosis. And also, there is a MYC oncogene, which is associated with neuroblastoma. And if MYC and oncogene is amplified, it has a very bad prognosis. Okay. How does this neuroblastoma look in histology? Neuroblastoma has what are these things which are called? You can see that there is a cells arranged somewhat like this, right? So this looks like a flower, or what we call in histology, this is called rosettes. Rosettes are very characteristic of neuroblastoma. You can see these rosettes over here, and this central pink material also you can see. This pink material is known as neuropil. Okay. So these rosettes are known as homoerite rosettes, which have pink material in between, which is neuropil, and surrounded by small undifferentiated cells, which are very small round looking cells. So these flower like rosettes, and then these small round cells. These are very characteristic histopathologic findings of neuroblastoma. Now we move on and discuss a few autoimmune thyroid diseases. We're going to discuss thyroiditis like Graves' disease and Hashimoto's thyroiditis. So before moving on, I just want to discuss a pathogenesis of these two diseases so that we can easily discuss their symptoms and their histopathologic findings. So what is the pathogenesis of these autoimmune diseases? So what is autoimmune disease? Autoimmune disease is nothing but the cells of our own immune system start attacking our own cells. Okay. Usually what happens, there is a protection within us that our own cells never attack our own immune cells like B cells and T cells. They do not attack our innate cells. For example, skin cells or thyroid cells or any other cells for that matter. But if this keeps happening, if our own immune system starts attacking cells in our body, then that is called as autoimmune disease. Why does this happen? It could be because of environmental factors, could be because of genetic factors. So, what happens in Hashimoto's thyroiditis is these autoantigens start producing, which start attacking our own thyroid cells. Okay, and this autoantibody which is produced is thyroid peroxidase antibody, which attacks the thyroid follicular cells of the thyroid. Okay, we had discussed about follicular cells in the last class. So follicular cells of thyroid is thyroid peroxidase antibody attacks the follicular cells of thyroid, and because of that, whatever thyroid hormone these follicular cells were supposed to produce, thyroxine. So the production of the thyroxine reduces. Okay, so similarly in Graves' disease, and autoantibodies are produced, but there is a slight change. Instead of attacking the thyroid follicular cells, it stimulates the thyroid follicular cells. Or you should remember that thyroid follicular cells have a receptor. Every cell has a receptor. Okay, thyroid follicular cell also has a receptor, which is thyroid stimulating hormone receptor. Okay, these autoantibodies, what they do, they mimic as thyroid stimulating hormone, and they stimulate this receptor, which in turn produces more and more thyroxine. Okay, so increase in thyroxine will be there. In Hashimoto's thyroiditis, these autoantibodies, thyroid peroxidase autoantibodies, they were destroying the follicles and resulting in decreased production of thyroxine. Whereas in Graves' disease, these autoantibodies, which are stimulating antibodies, they stimulate the thyroid receptor and they increase the production of thyroxine. Okay, so these are the things which I need you to remember. Now we are going to discuss thyrotoxicosis. Thyrotoxicosis is a condition caused by excess thyroid hormone leading to hypermetabolic symptoms. Okay, so what are the causes of thyrotoxicosis? We have Graves' disease, which is a common cause of thyrotoxicosis, as I have mentioned earlier. It is because of thyroid receptor antibodies which are stimulating in nature. Because of these stimulating antibodies, the thyroid follicular cells increase thyroxine production, and because of thyroxine production, we have thyrotoxicosis. I will just tell you in a bit what thyrotoxicosis is. And then toxic multinodular goiter again increases the production of thyroid hormone, which is thyroxine. Also, exogenous thyroid hormone intake can also result in thyrotoxicosis. Okay. Again, similar to cortisol, pituitary produces thyroid stimulating hormone. Okay. And this thyroid stimulating hormone acts on cells in thyroid, which results in increased thyroid hormone. But what happens in Graves' disease is this thyroid stimulating hormone, these antibodies actually mimic thyroid stimulating hormone. When these antibodies mimic thyroid stimulating hormone, what happens is these the cells of the thyroid gland, they think, okay, this is thyroid stimulating hormone, so I should secrete more and more thyroid hormones. So it goes ahead and secrete more and more thyroid hormones. Now, what is the function of thyroid hormone? Thyroid hormone's function is increased metabolism, increased heart rate. Okay, increased heart rate, increased metabolism. Okay, also there are certain other symptoms which can occur because of this. These antibodies which are produced by this thyroid stimulating antibodies. So, what are these? First, we know that hyperthyroidism because of increased follicular hypertrophy. And then these antibodies also stimulate orbital fibroblasts and adipocytes. Okay. And also stimulate skin fibroblasts. This results in ocular manifestations and also skin manifestations in Graves' disease. Okay. If you are able to draw these diagrams in your exam very well. Okay. So remember these flow charts and try to draw them in your exams. It will be very. Okay, so what are the symptoms of thyrotoxicosis? We have weight loss because increased metabolism, increased heart rate, heat tolerance, tachycardia, tremors, anxiety, and muscle weakness are all symptoms of thyrotoxicosis. So we know what will be the clinical features and what will be the laboratory features in this case. Since we have increased thyroxine, T3 and T4 will be increased and TSH will be reduced. Why TSH will be reduced? Because T3 and T4 are already increased. What will happen? The pituitary thinks that, okay, there are enough thyroid hormones, so why should I make more TSH? So there is a negative feedback mechanism which goes back and reduces the production of TSH. So this negative, because of this negative feedback, whenever there is increase in T3 and T4, that is thyroid hormones, there will automatically be decrease in TSH. Okay, so that is the reason why elevated TSH is there along with. That is the reason why elevated T3 and T4 is there along with suppressed TSH in Graves' disease. Okay. So what are the histopathological findings in Graves' disease? In Graves' disease, we can see there are tall columnar cells over here. Okay. There are tall, your follicle is somewhat like this, and tall columnar cells along with colloid is also scalloped. So as you can remember, yesterday, I think we discussed in our previous class that thyroid follicle cells will be round in shape, okay, and there will be and colloid, and usually the cells are flattened or cuboidal. In contrast, we have tall columnar cells over here, which secrete colloid, and they have a very scalloped appearance instead of the normal round appearance. So this is a feature of hyperplastic thyroid gland. Okay. What is the management? Antithyroid drugs like methimazole, propylthiourate, Radioiodine therapy can be given and surgery can be performed in cases which cannot be medically treated. Hashimoto's thyroiditis, next one. So, Hashimoto's thyroiditis also we have discussed the pathophysiology. It is an autoimmune disorder where the immune system lacks the thyroid leading to thyroid hormone leading to hypothyroidism. Okay, so symptoms will be totally opposite to our Graves' disease. So, Graves' disease had weight loss, Hashimoto weight gain. Graves' disease had heat intolerance. Here it is cold intolerance because the hormone is not there. Goiter, dry skin, and depression. Right. So diagnosis also will be this thyroid profile will also be totally opposite to whatever we saw in Graves' disease. So you have to remember in Graves' disease there was elevated T3 and T4. So because of elevated T3 and T4, the pituitary will think that okay, enough of TSH, now I'm stop producing TSH and reduced TSH. Okay, but in Hashimoto's thyroiditis, what will happen? That the antibodies which are produced, which are thyroid peroxidase antibodies, they are destroying the thyroid gland. When they are destroying the thyroid gland, T3 and T4 levels are less. Whenever T3 and T4 levels are less, what will happen? Pituitary will think, okay, there's no T3 and T4, so I have to produce more and more TSH and hence increase in TSH. So that is what happens here, elevated TSH with low T3 and T4. Okay. So positive anti-thyroid peroxidase antibodies as well. So what will be the histologic findings in Hashimoto's thyroiditis? So dense infiltrates of lymphocytes and plasma cells. There are dense infiltrates of lymphocytes and plasma cells. It can also form a lymphoid follicle-like appearance. Okay. Hurdle cells can be seen over here. Hurdle cells are nothing but thyroid follicle cells which have become more eosinophilic in appearance. Okay, they have become more eosinophilic in appearance. Why have they become more eosinophilic in appearance? They have increased mitochondria. Because of increase in mitochondria, they take up more and more eosinophilic states and they become more eosinophilic in appearance. So these cells are called hurdle cells and these can be seen in Hashimoto's thyroiditis. Fibrosis can occur in very late stages. So what would you give as treatment in this patient? In this patient, the treatment would be thyroxine. Because there is lack of thyroxine, there is reduced thyroxine, so you have to supplement thyroxine in these patients. Okay. The next question which we are going to discuss is goiter and its subtypes. So what are the types of goiter? There can be simple goiter which can be caused by iodine deficiency. There can be multinodular goiter with multiple nodules and this may or may not have increased thyroid hormones or there can be normal thyroid hormones also. But toxic goiter is associated with Graves' disease. We have discussed this earlier as well. Toxic goiter is associated with Graves' disease and increased thyroid hormone production. Okay. Non-toxic goiter, there will be enlargement but without any hormone production. So what is the treatment in these cases? Whenever there is iodine deficiency, iodine can be supplemented. Okay. Whenever there is thyroid hormone, decreasing thyroid hormone replacement can be done. And if it is a large goiter which is actually affecting this appearance or it is compressing the esophagus and compressing any nerves, then surgery can be done in these cases. Okay. Next, I will be discussing type 1 diabetes mellitus. What is the definition of type 1 diabetes? Type 1 diabetes is an autoimmune disease characterized by the destruction of insulin-producing beta cells in the pancreas. So as we know, type 1 diabetes is autoimmune. Autoimmune, again, as we already discussed, the autoantibodies, they destroy beta cells in the pancreas, our own autoantibodies. Type 2 diabetes type 2 diabetes is not an autoimmune disease, okay? And it is also known as insulin non-dependent diabetes, whereas this is insulin dependent diabetes because insulin producing beta cells are totally being destroyed over here. What are the symptoms? Polyuria, polydipsia, weight loss, and ketoacidosis can occur in later stages. How will you diagnose these cases? Elevated blood glucose, low C-peptide levels. So I will just give a little bit overview about C-peptide. What happens is when insulin is produced by the beta cells of pancreas, whenever insulin is produced as proinsulin. Okay, proinsulin has C-peptide along with insulin. Okay, so this proinsulin is cleaved into C-peptide and insulin. So it comes in whenever it comes into the bloodstream. We have C-peptide as well as insulin whenever it is produced in the beta cells. But since here insulin is not produced, you don't have C-peptide here as well. So this is the reason we have low C-peptide in type 1 diabetes mellitus. Again, some autoantibodies such as anti-GAD antibodies and islet cell antibodies, ICA islet cell antibodies, these antibodies can also be associated with type 1 diabetes. All right. So what will you do for management? For management, insulin therapy should be given and blood glucose monitoring should be done. Okay. So histopathologic findings. What are the histopathologic findings here? There will be islet cell destruction and lymphocytic infiltration, as we saw. Wherever there is autoimmunity, you can see lymphocytic infiltration most of the times, and there is beta cell loss because these lymphoid cells are destroying beta cells. There is significant reduction in beta cell. Okay. So now the most very important thing. This is very commonly asked in your exam. You have to read this. There is no other book. It has been asked in many papers. So definitely read multiple endocrine neoplasias and do try to recreate this table in your exam. If you recreate this table, the examiner will think that, okay, this person has read it and you might get more marks also. So definition, this is a group of inherited disorders affecting multiple endocrine organs. So what are the endocrine organs which are affected? MEN1 syndrome. You have parathyroid hyperplasia, pancreatic tumor, and pituitary adenoma. Okay, this is a mnemonic which you can use, which you can remember. And MEN2A, it's also known as sickle syndrome. So what are the syndromes? What are the diseases associated with MEN2A? Parathyroid hyperplasia, medullary thyroid carcinoma, and pheochromocytoma. Okay, remember no pheochromocytoma in MEN1. Remember in MEN1, parathyroid is associated. You can actually remember by parathyroid, pancreas, and pituitary. MEN2A, just remember parathyroid, pancreas, and pituitary. And medullary carcinoma only with MEN2A and MEN2B. Okay, and marfanoid habitus only with MEN2B. Okay, so what is the management of these tumors? Surgical removal and genetic counseling, because this is a genetic condition and this is inherited. Genetic counseling can be done to see if any other member in the family is suffering from the same disease. Now let's move on and discuss some short answer questions. So the short answer questions are 3 marks. So I will just quickly tell you what are the points your examiner wants to know, and you can just mention or underline them. Another important thing which I forgot to tell you is you should underline the important things. Whenever you find, okay, this is important, you have to underline. If you underline it, it will highlight and the examiner can see, okay, so you have read whatever is. Short answer questions, we have tumors of adrenal medulla. This we have already discussed, that we have pheochromocytoma, secretes catecholamines produced in the, we know the functions of catecholamines, you can mention the function of catecholamines, and you can also mention the histomorphologic features of pheochromocytoma. Again, neuroblastoma you already mentioned, you can mention the histologic features of neuroblastoma. What are goitrogens? So now, goitrogens are certain substances which interfere with the thyroid hormone. So what happens? So there are certain vegetables like cabbage and cauliflower, and also certain medicines like thiocyanins. So these substances tend to inhibit thyroid hormone and decrease the thyroid hormone production. So why this is important? Why goitrogens are important? So somebody is already suffering from Hashimoto's thyroiditis, and these goitrogens inhibit or reduce the thyroid hormone production. So in this case, what happens? their disease further worsens. So that is why it's essential to know that these are goitrogens, so that we can avoid patients of Hashimoto's thyroiditis or patients who are suffering from decreased thyroid hormone for any other reason. They can avoid eating these vegetables, so that it further does not decrease the thyroid hormone levels. Okay. Next short answer question we are going to discuss is renal glycosuria. So what is renal glycosuria? What is glycosuria first? Glycosuria is the presence of glucose in urine. So presence of glucose in urine itself is abnormal? No, it is not abnormal. Presence of glucose in urine more than a certain extent is abnormal. Okay. So what happens? What are the conditions causing glycosuria? You have diabetes. Diabetes is the most common cause of glycosuria. So glucose is excreted in the urine despite normal blood glucose level. This is known as renal glycosuria. It is caused by a genetic defect. What happens in the kidney? There are SGLT2 transporters. So if there is defect in these transporters, what happens is from the blood, glucose travels into the lumen of the kidney. When it goes into the lumen of the kidney, it gets excreted. So in these cases, even if the blood glucose level is normal, the patient is a non-diabetic, still renal glycosuria would be there. So in these cases, we have to evaluate for SGLT2 transporter defects. So that is why it's important in the presence of normal blood glucose level. So these things are very important, and you have to mention these two words, that in the presence of normal glucose level, you have to define this. In the presence of normal glucose level, if there is excretion of glucose in the urine, it is known as renal glycosuria. Also, you have to mention that this is due to a defect in SGLT2 transporters. Okay. So, types of thyroid tumors. This we have discussed in our previous class. There are benign thyroid tumors as well as malignant thyroid tumors. Okay. So, we have discussed this elaborately in our previous lesson. Pathogenesis of thyrotoxicosis. This we have just discussed this in our short essay question, but I will just overview what are the important points that you have to write. So thyrotoxicosis is nothing but overproduction of thyroid hormones. So whenever there is overproduction of thyroid hormones, it can be either due to autoimmunity, like we have discussed in Graves' disease, or due to a toxic goiter, which causes increased production of thyroxine, or it can be directly due to increased thyroxine intake. Right? So these are the reasons. This leads to increased metabolic rate. So what does thyroxine do? It increases heart rate, it increases metabolism, it causes weight loss. So all these things happen. Okay. So you can give an overview of how autoimmunity occurs in Graves' disease and what are histologic features and all these things. That's it for today's class. Thank you very much.